El primer ponente es el doctor Ulrich Specks, que presentarlo es difícil, pero realmente una manera de resumir sería el hombre que sabe todo de las vasculitis, tanto desde los mecanismos fisiopatológicos como también del tratamiento. Sin más, Dr. Specks, when you want.
Well, thank you very much for the nice introduction, and I have to thank you for putting up this meeting and inviting me. This has been really a fantastic visit so far. Granada is so beautiful. I'm really looking forward to spending a couple of additional days here. I have to ask you all a question. Who is not a nephrologist in this group? Well, nephropathologists don't count. Okay, so I'm sorry for you back there, but for this presentation, even though we're dealing with systemic disease, I'll stay below the diaphragm mostly, and you'll see why. You'll realize that the kidneys are actually important, and it's hard for me to say that as a pulmonologist, but I've learned this the hard way over the last 30 years. So these are my disclosures. What we'll do, we'll review the ANCA-associated vasculitides, which affect the small vessels and the capillaries, and in the lung they lead to alveolar hemorrhage as a result of capillaritis, and you're all familiar with the necrotizing focal segmental glomerulonephritis. And the association of this systemic diseases, when we focus on what's now called granulomatosis with polyangiitis, or GPA, and microscopic polyangiitis, or MPA, they are associated with autoantibodies that are directed against two target antigens. One, proteinase 3 or PR3, giving you this cytoplasmic staining pattern on ethanol-fixed neutrophils. And the other variety of interest in the context of vasculitis is the antibody directed against myeloperoxidase, giving you a perinuclear staining pattern on ethanol-fixed neutrophils. Now, even though we talk about GPA and MPA, one theme that has emerged over the last few years is the insight that the separation of these syndromes by the ANCA type, PR3 versus MPO ANCA-associated disease, is probably clinically more relevant, and there is significant support for it from a genetic basis. If you divide genetic abnormalities by PR3 versus by PR3 versus MPO ANCA, and you do the same thing by GPA versus MPA, you get a stronger statistical significance of the separation by ANCA type. The same goes for cytokine patterns at the time of initial presentation during active disease, and the relapse rate, microscopic polyangiitis, MPO ANCA-associated disease does not relapse nearly as often as PR3 ANCA-associated disease does, and you'll see that treatment response to rituximab is also subtly different between the two PR3 ANCA versus MPO ANCA disease. So what I hope you walk away from this afternoon is an understanding of the state-of-the-art treatment for GPA and MPA, and you recognize the unmet needs in 2019, and you're able to understand the most significant clinical trials that are currently ongoing and where they're leading and why we're doing them, and in that context understand the general direction of where clinical research in ANCA-associated vasculitis is going. So the talk is organized in focusing first on where we stand in 2019, but then zeroing in very quickly on the unmet need of the management of these diseases. And we separate it out into looking first at remission induction, and then we're looking at remission maintenance. So where are we now? Well, the mortality of the disease in this case is on GPA, and a study based on a UK group is affecting patients' mortality. But if you separate the mortality observed with the disease from the decade 2 decades ago versus one decade ago, there is significant improvement between the decades. And this is the result of improvement in treatment and management as we've learned to use the conventional drugs better. What this does not quite reflect yet is where we are in the long-term mortality during the treatment, mostly with glucocorticoids and rituximab. Now, the same is observed for the hospital mortality of GPA in the United States. It has come down gradually over the decades and is approaching that of the general hospitalized population in the United States. And we looked at the incidence and outcomes of ANCA-associated vasculitis in Olmsted County. Olmsted County is where the Mayo Clinic is, and it is a very well-defined population where we have complete access at all medical records. And a lot of epidemiological studies have come out of that database, and we confirmed that it is a rare disease. So in combination, GPA, MPA, and eGPA make up for about 3.3 new cases per 100,000 people. That comes to a prevalence of 42 patients per 100,000. But what was kind of a surprise to us is that actually MPA made up almost half of the overall incidence and was more than GPA. And what also was a little bit of a surprise that in our patient population in this day and age, GPA's mortality no longer is different from that of the general patient population. And this is probably the case because we capture all patients with GPA, and for many patients, the disease manifestations are north of the diaphragm, and only about eventually 70% of GPA will have some form of renal involvement. But when the patients with MPA come to attention, they're older, and they usually have a renal involvement, and the renal involvement is fairly advanced by the time they come to medical attention, and hence their increased mortality. This slide just summarizes remission induction therapy for ANCA-associated vasculitis in 2019, and you don't really need to be too concerned about non-severe GPA because you're mostly nephrologists, so you see the patients when they have glomerulonephritis, and that is by definition severe disease because it has not only a tendency but almost a certainty to affect the organ with irreversible damage if not treated quickly and efficiently. So for severe disease, and this briefly summarizes where we stand with using rituximab versus cyclophosphamide, the RAVE trial has shown that rituximab is non-inferior to cyclophosphamide for severe ANCA-associated vasculitis, defined as either life-threatening or threatening the affected organ with the risk of irreversible damage. And this includes patients who were in the trial with major renal involvement as well as diffuse alveolar hemorrhage, and you'll see a little bit more of the details of that. But rituximab was also found to be superior to cyclophosphamide in relapsing patients. So if you entered the trial with a relapse, rituximab was the better choice, and that also held up when we analyzed the patients by PR3 ANCA versus MPO ANCA. So amongst PR3 ANCA patients, rituximab was superior versus MPO ANCA positive patients, rituximab and cyclophosphamide were exactly the same. Now, so it's not really a surprise because I already mentioned PR3 ANCA patients have a tendency to relapse, so the relapsers and the PR3 ANCA positive patients had more overlap. So you may say, well, what should I use if it's not inferior? Should I use rituximab or should I use cyclophosphamide? And when should we give preference to rituximab versus cyclophosphamide? Well, in this discussion about healthcare costs, which inevitably comes up, we compare drug prices. And that is probably a big fallacy because when we have these discussions, we need to take a broader view. We need to certainly be concerned about the drug cost, but the drugs and their application and their costs differ quite substantially depending on which healthcare system they're applied in, which insurance system is that the patient lives in, and what is the overall cost associated with the overall treatment, including the likelihood of developing relapses with subsequent damage and the cost thereof. So the economic cost beyond the insurance cost of the initial treatment is really what we should all be concerned about. And when that is analyzed, rituximab actually does come out fairly comparable to cyclophosphamide, at least for patients who present with relapsing disease. The British in the Oxford group analyzed the RAVE and rituximab data and did an economical modeling analysis with those data, and they concluded that rituximab was cost-effective for relapsing patients. They did not do the analysis by ANCA type, and based on what we know about the overall treatment response, relapsing versus new diagnosis, PR3 ANCA versus MPO ANCA, I would bet my money that it was only also come out as cost-effective for PR3 ANCA-associated disease. Before we talk more about rituximab or cyclophosphamide in special situations, I want to get right into disbanding a myth. The myth is out there that cyclophosphamide should be used instead of rituximab or added to rituximab for patients with severe renal disease or respiratory failure. Well, where does that myth come from? Well, it comes from the fact that we don't have clear-cut data for these severe disease patients. At least we didn't have many as of yet. And we certainly don't have a whole lot of data on cyclophosphamide in that setting. We're just using it traditionally. And it's always hard to get rid of traditions. But I'll show you a few data that will make you hopefully think about the diffuse alveolar hemorrhage and severe renal disease differently. So the main argument that's often brought forward is that the RAVE trial, which showed that rituximab is superior for relapsing patients and non-inferior in all contexts, excluded patients with severe renal disease because it excluded patients who had a serum creatinine greater than 4 due to their active disease at the time of enrollment, and it excluded patients requiring mechanical ventilation for the treatment of their diffuse alveolar hemorrhage. But you're all biologically thinking, so I'd challenge you that the only reason out there, the rituximab trial giving 2 cyclophosphamide infusions together with rituximab in patients who had severe renal disease, and some of which had severe alveolar hemorrhage, that led to this assumption that, yeah, we should use it in those most severe disease patients. But the exclusion in the RAVE trial was really just one that the safety DSMB imposed on us for good reasons at the time, because we didn't know how it was going to come out, of course. But I'd argue that a patient that you see on Friday afternoon with a creatinine of 2.8 in your clinic, and you send a patient into the hospital, by Monday, the patient has a serum creatinine of 4.2. If you had the patient sign the consent form in your clinic on Friday afternoon, the patient would have been in the trial. If you had have the patient sign the consent form on Monday morning when the creatinine was 4.2, the patient would have been excluded from the trial. The same goes for patients with diffuse alveolar hemorrhage. The patient shows up with diffuse infiltrates and a halfway decent oxygenation Friday afternoon. You send them appropriately to the hospital to be in a safe environment. You had them sign the consent form and they're in RAVE. Monday morning they're in the ICU on the respirator. Same disease 3 days later, same biology. Why would we expect a different response to the treatment from the different agents just because the disease progressed rapidly? So keep that in mind when we look at the next day. And this is just a confirmation that 25%, quarter of the patients that entered RAVE actually did have diffuse alveolar hemorrhage, and very few progressed to being up on the respirator, and they were counted as treatment failures. But the rest did respond to the treatment in exactly the same way as the overall patient population as a whole. So you can conclude that, maybe the drug response is similar in similar biological situations. And we wanted to know this in our patient population at the Mayo Clinic, and we did a retrospective analysis of all patients who ended up in the intensive care unit, or in the hospital, I should say, with diffuse alveolar hemorrhage caused by GPA and MPA. And we at Mayo have never given the combination of cyclophosphamide with rituximab, so they either got cyclophosphamide or they got rituximab. So that allowed a very nice analysis of these patients and how they did. And we found that the hospital mortality, the hospital lengths of stay, the ICU lengths of stay, the days on mechanical ventilation were exactly the same in both treatment groups. However, what was different was the 6 months complete remission rate, and that's the endpoint of the RAVE trial also, complete remission being defined as no measurable vasculitis activity and having completed the prednisone taper down to 0. And there, rituximab did better than cyclophosphamide. We also looked, and this is unpublished data, so please don't take any photos. This will be presented in abstract form next week at the International ANCA and Vasculitis meeting. We also looked at our patient population with severe renal disease for over the last 20 years, defined as an estimated glomerular filtration rate of less than 30 milliliters per minute. And there was a significant difference in favor of rituximab of requiring renal replacement therapy at any time during the observation. But remission, renal remission, death, and end-stage renal failure at 24 months were exactly the same or not significantly different, and if anything, favoring rituximab a little bit. Now, you can argue most of the cyclophosphamide patients were probably treated earlier and more later on as we got better with our overall supportive care. The patients got more rituximab. So for those reasons, we did a propensity score analysis to adjust for treatment-related factors, type of immunosuppression or plasma exchange, treatment with intravenous methylprednisolone, yes or no, and disease severity-related factors like having very severe renal disease with an eGFR less than 15, or having the presence of alveolar hemorrhage, which is in and of itself a factor that puts the patient at risk for dying during the early phase of the disease. And there was really no difference statistically, although if you look at the hazard ratio, it came very close to being significantly in favor of rituximab. So at least in this patient population with severe renal disease, rituximab is not worse than cyclophosphamide. If anything, it may be even having an edge. So what about adding 2 infusions of cyclophosphamide to rituximab? Well, we don't have a whole lot of data on that, but Dr. Geetha from Johns Hopkins, together with David Jane, looked at the Johns Hopkins and Cambridge data together, and they separated their patients into those that had received rituximab and glucocorticoids alone versus rituximab plus cyclophosphamide. And in the 2 groups, there was no difference in the baseline glomerular filtration rate, whether Plex was used or not, whether rituximab dosing regimen was 1 gram times 2 weeks apart, or the lymphoma regimen, the 375 milligrams times 4 once a week. And the outcomes were absolutely the same between these 2 granted fairly small groups. But there was no difference in remission at 6 months, no difference in end-stage renal disease, no difference in death, and no difference in recovery of renal disease. So whatever data we have certainly does not support the need for adding cyclophosphamide boluses to remission induction treatment with rituximab. So in 2019 or 18, 2019, all the same, we can say that additional studies beyond the RAVE trial have shown that rituximab is at least as good as cyclophosphamide in patients with severe renal disease, as well as in patients with alveolar hemorrhage, even those who end up on the respirator. So this is a graph that is a little bit dated. It looks at the overall mortality of the patients enrolled in all the clinical trials conducted by the European Vasculitis Study Group. And what is really of interest is that maybe it's not a surprise, but there is an early increased mortality that it occurs in the first 3 months, and then it flattens out and approaches more the decline of the general patient population. So really this is where we can probably make the biggest mark in advancing treatments going forward. And in this context, we need to look at what made up most of the 1-year mortality, and 50% of the 1-year mortality is due to infections and sepsis. So patients die in the ICUs and in the hospital of severe infections, at least half of them, when only 20% of the mortality was really attributable to inadequately controlled active vasculitis. There's, of course, other reasons to die, but this is really what grabs our attention. So maybe we're overdoing it with our immunosuppression in the very early phase of the disease, and maybe we can do better, hopefully with less glucocorticoids, and this is really where the focus is. Now, the second important thing is, and this pains me to say, but it's all about the kidneys. The outcome of patients with ANCA-associated vasculitis is clearly defined, and this is a Dutch study that showed that very nicely, that really it's about the renal function at 6 months. So in this study, they separated patients who had renal involvement and did not require renal replacement therapy, and patients who had renal involvement and required renal replacement therapy. And it's of interest that the patients who don't end up on dialysis have the same overall outcomes as patients who didn't have any renal disease in the first place. But once they have renal function loss to the degree of requiring renal replacement therapy, their mortality is very, very bad. Now, that's of course not a surprise to you nephrologists, because it's probably true for any type of renal disease that once it adds up to be quite bad in terms of the renal function, the overall prognosis is worse. So where's the unmet need in 2019? What are the open questions? I think we clearly need to improve on the early mortality. We need, and this comes with the need for minimizing toxicity, particularly the high-dose glucocorticoid-associated toxicity. And of course, we need to minimize the damage that puts the patients at risk for further problems down the road. And particularly, we want to preserve as much renal function as possible, because that is the single most defining overall outcome factor. So how can we do this? Is there a role for plasma exchange, adding plasma exchange to our standard treatment? Are there new drugs that can potentially affect the early mortality? Well, let's visit those two possibilities in a little bit more detail with currently available data. So I'll challenge you before you all fall asleep after the nice beer and wine and good food. So plasma exchange should be used in which of the following patients? And you have 5 options. So patients with severe renal disease defined as creatinine greater than 5.6 milligrams per deciliter, patient presenting with alveolar hemorrhage, patients with serum ANCA and serum anti-GBM, all of the above, none of the above. Who's for A? You're up to the literature. Who's for B? Okay. Who's for C? A few more. Who's for D? Oh, majority. Who's for E? All right, so it's a trick question. There's probably not a right answer, truly, but the best answer in parlance with test taking is C. So I'll show you data for all the others, but C is the one where your intervention really will make a difference. Anti-GBM disease is the only disease which hits the kidney hard all at once, and if you don't do something definitive to change that, that kidney is lost. So for plasma exchange and anti-GBM, there is absolutely no discussion. Now, the trick here is serum anti-GBM. Now, there are double positive ANCA and anti-GBM, and they have a tendency to do worse than just ANCA alone. But most serum anti-GBM is not quite as specific as a renal biopsy. And in order to really show that the anti-GBM is pathogenic, you need to show that you have linear staining on the renal biopsy, because sometimes if you have a positive serum anti-GBM, of course, it comes back negative on the biopsy. But if time is of the essence, then you shoot first and ask questions later, because the renal biopsy won't come back until a few days, if you're lucky, like we are at the Mayo Clinic, or a week or so later. So that's the best answer, and I'll show you data why the others aren't. So talking about plasma exchange in ANCA-associated vasculitis and enthusiasm goes back to this old study that was designed in the 1990s and finally published in 2007, the MEPEX trial, where patients received prednisone and cyclophosphamide, and in addition, they were randomized to either receive plasma exchange or intravenous methylprednisolone. Now, you can argue about the trial design. Nowadays, we would give IV methylprednisolone to everyone and then give half the patients plasma exchange and the other half no plasma exchange. But this was the initial enthusiasm-inducing data set where the patients with plasma exchange did substantially better initially in terms of surviving and being dialysis independent compared to just intravenous methylprednisolone. But when you did a long-term analysis and followed the patients out over years, this initial difference evaporated very quickly, and in terms of long-term outcome, there was no observable significant benefit between those that received plasma exchange and those that didn't. And Mike Walsh and David Jane and Peter Merkel and a few others went to the funding agencies, including the MRC and the FDA, and they got money to support a large global randomized controlled trial of plasma exchange versus no plasma exchange in severe ANCA-associated vasculitis. And that was the Pexivas trial. That was the most ambitious undertaking in ANCA-associated vasculitis to this day. 700 patients were enrolled worldwide in this trial, and this trial addressed two important questions. In addition to looking at plasma exchange versus no plasma exchange, patients were also randomized to two different glucocorticoid tapering regimens, keeping in mind that half of the patients that die early die of infections. So maybe there is an advantage of being more judicious with our prednisone use. So patients who either received the standard dosing regimen taper or a reduced or accelerated tapering regimen. And the primary outcome was that of the preliminary data, the MEPEX trial, a combined outcome of end-stage renal disease or death. Now, the data have been presented in abstract form and they are submitted for publication in a peer-reviewed journal. But the headlines, data, or conclusions from the trial are there is no benefit to plasma exchange. And it doesn't matter which patient subgroup we looked at, severe renal disease or alveolar hemorrhage or the entire cohort, there was not one iota of benefit from plasma exchange. But the most significant, probably practice-changing outcome is that the reduced prednisone dosing regimen was actually better than the standard prednisone tapering regimen. The primary outcome and the secondary efficacy outcomes were the same in both treatment arms. So we can achieve the same efficacy with less. But the infection rate was higher in the standard group compared to the lower group. So we can do better on the toxicity side of it by giving less glucocorticoids. And this will probably in the next few years trickle into practice and hopefully along the way save a few lives. Now, what about remission induction in severe renal disease at the Mayo Clinic? Plasma exchange versus no plasma exchange. Again, we looked in our series of 211 patients, and what was different in the PLEX group versus no PLEX group was that fewer patients who received PLEX required hemodialysis at any given point, but the end-stage renal disease at 24 months and death at 24 months or their combination were not statistically significantly different. Remission at 6 months and renal remission at 6 months were also not different between the two groups. Now, you may argue that the sicker patients probably got plasma exchange and the healthier patients did not, and that's probably true. And for that reason, we again did a propensity score adjustment for the same factors that I already showed you previously. And there was absolutely no difference. This is actually the cumulative serum end-stage renal disease and death date over time. So the endpoint of the Pexivas trial and the MEPEX trials that were looked at, there was actually an advantage for the, there were no significant difference between PLEX or no PLEX after adjusting for disease severity is the bottom line. So again, even in this retrospective study, there was no signal that would benefit plasma exchange in this patient population. And what about the severe alveolar hemorrhage group? We did a similar analysis, and that's been published already. Everyone received methylprednisolone. 32 patients received plasma exchange of the 73, the others did not. And after adjusting for the probability to receive plasma exchange and for the induction agents, rituximab versus cyclophosphamide, there was no association or no benefit of a plasma exchange when it came to the complete remission rate at 6 months. So even in the subset of diffuse alveolar hemorrhage at Mayo, there was also no apparent advantage. So when you look at data in the literature, and we summarize this in that same publication, it's very hard to tease out meaningful information about the subset of patients with diffuse alveolar hemorrhage, but the studies that do provide data, including the study from the Chapel Hill group that actually really got patients to think about using plasma exchange in diffuse alveolar hemorrhage due to ANCA-associated vasculitis, when you add it all up, there was no advantage in hospital survival of these patients, whether they received plasma exchange or not. So, what about novel drugs? Can we do better with novel drugs? The interference with the activated complement factor 5A, or C5A, with its receptor is the mechanism that is being looked at. And the reason for this interest goes back to the mouse model of MPO ANCA-associated vasculitis from the Chapel Hill group. And they were able to show that the lesions are complement dependent and that an intact alternative pathway is required for the lesions to develop. And in the mice that had no C5a receptor on the neutrophils, they could not develop the model to play out. And in the wild-type mice, if they blocked C5a with anti-C5a monoclonal antibody, they could also use this as a therapeutic agent. And this preclinical data really formed the basis for the company to look at an agent called CCX168, which is now going under the name Avacopan in a phase 2 trial. And the phase 2 trial really got everyone excited about something new, possibly allowing us to treat the initial phase of the disease without glucocorticoids. And in terms of inducing remission or putting a kibosh on the disease activity, there was no statistical significance in the patients who received avacopan alone, avacopan plus some glucocorticoids versus the standard glucocorticoid regimen alone. But what really got the nephrologists all excited, and remember it's all about damage to the kidney, is this preliminary data. They looked at the urine albumin to creatinine ratio, which is thought to be a marker of early renal damage, and there was at 4 weeks a substantial difference between the patients who received avacopan, either alone or with a little bit of steroids, versus those who received standard glucocorticoid regimen but no avacopan. So that got everyone excited. Maybe we can do better early on, saving more nephrons early on and thereby even turning around the overall outcome of these patients. And this led to the phase 3 trial that really compared head-to-head no prednisone plus avacopan versus standard prednisone and avacopan placebo in 150 patients each. This trial has completed enrollment last June. We're expecting the data sometimes this fall, and this will be very exciting to see how that comes out, because if the trial delivers on its promise, we will use hardly any glucocorticoids beyond the first week of management of ANCA-associated vasculitis. We'll see how it comes out. Well, with that, let's switch briefly for the remainder of the talk to maintenance. Most of what we have for data of maintenance goes back to maintenance trials following induction with cyclophosphamide. And following induction with cyclophosphamide, azathioprine is on par with methotrexate. Of course, you guys never use methotrexate because that's a no-no in any degree of renal insufficiency. But north of the diaphragm, we use it quite a bit. And it really depends on the patient whether you go with azathioprine or methotrexate for maintenance in these patients. Mycophenolate mofetil has gotten a little bit of a bad rap because it was compared to azathioprine in a single trial, and there was a higher relapse rate in the patients who received mycophenolate mofetil. I say the drug probably got a bad rap because there is overall, when you look at all the patients in the table, no meaningful clinical significant difference, except for one. If you go and look at the table, and Dr. Fervenza quoted me earlier as saying the devil is always in the detail, and so here it comes. Look at the table. There was one statistically significant difference in the mycophenolate group versus azathioprine group. And that was the C-reactive protein level at the time of randomization, which was significantly higher in the mycophenolate mofetil group. So I would argue that even though we couldn't measure it clinically, there was more background smoldering disease activity in the mycophenolate patients by the unlucky draw of randomization than in the azathioprine group. And the minute they ended up on those agents, there was more hangover in from cyclophosphamide in the AZA group, and the patients with mycophenolate relapsed early. And then after that early relapse was gone, the lines were parallel. So that's why I'm saying mycophenolate probably got a bad rep, but you can use it in patients who failed azathioprine or have contraindications for azathioprine. You'll probably achieve the same. Now, that is also preceded, as you will see, by the results from the Main-Ritzan study and a couple of other non-randomized trials where rituximab has been emerging as being more effective for remission maintenance than azathioprine. So, with that, let's focus on how we can individualize treatment in maintenance. How can we get biomarkers that predict a relapse accurately, and how can we target the necessary treatment to the right patient so that we don't overtreat the patients who don't need it? So when we talk about remission maintenance, it's always about the balance of the risk of the relapse, which is associated with the risk of more damage to an already pre-damaged kidney, for instance, and it is associated with the additional toxicity and cumulative morbidity coming from repeated exposure to glucocorticoids required to get disease activity under control acutely, versus the toxicities of the maintenance agent. Now, the most effective maintenance agent that we knew of until rituximab came about was cyclophosphamide. But we've learned in the early 1990s not to use cyclophosphamide beyond 6 months, because then the toxicity signal was taking over so rampantly, and that's where azathioprine and methotrexate came in as saviors. But what about this balance in the day and age of rituximab? Now, I already mentioned we need to identify the patient who needs remission maintenance therapy and separate them from those who don't. And we started with saying the ANCA type matters. And I'd like to remind you that in the RAVE trial, and this is just an example of several studies that have shown similar relationships, if you have newly diagnosed MPO ANCA positive microscopic polyangiitis, patient probably doesn't relapse, with very few exceptions. Whereas if you have relapsing GPA PR3 ANCA positive, you have a very high relapse rate. And then if you look at the treatment arms, cyclophosphamide versus rituximab, you see the same relationship of relapses, only you have a frame shift in the patients who are at highest risk for relapse. The AZA patients started to relapse right away once the cyclophosphamide washed out of the system, versus the patients who received rituximab started to relapse once their B cells came back. So it makes you wonder, what are we really doing with azathioprine in patients who are at the highest risk for relapse, namely the PR3 ANCA positive relapsing GPA patients? Well, we can go back, we can skip this at the moment, and we can skip this for the sake of time too. That looks at abatacept. There is a trial ongoing that looks at the T cell abnormalities and probably using CTLA-4 Ig as a maintenance agent targeting the T cell co-stimulation and thereby preventing relapses. But at the moment, all the rage is about rituximab as a maintenance agent, and this goes back to the Meinritzon trial that showed very clearly that patients who received 500 milligrams of rituximab every 6 months had a much lower relapse risk than the patients who received azathioprine. And all of this was after induction with glucocorticoids and cyclophosphamide. And the long-term data showed that this same relationship was maintained over 60 months. So this separation, once induced, was maintained long-term. Now, you can again ask, well, what does it cost? Well, the French did a very nice cost-effectiveness analysis of this regimen, and they presented this at the last ANCA meeting in 2017 in Tokyo, and unfortunately I've not seen the paper out yet, but maybe I missed it. They were able to show that the higher drug costs were offset by the higher relapse rate and the resulting renal damage. So, meaning if you can prevent a few patients from ending up on dialysis, rituximab really becomes cost effective. And they were able to put a euro number on this, and they said you need to spend 259 euros to avoid one relapse. So in the US, we added a couple of zeros to that, and then it's pretty accurate. So, but it may be cost effective using a very effective treatment long term. Now, what about the toxicity long term? So far, we haven't seen much, but we hope to get more data on the long term toxicity of prolonged B cell depletion through scheduled retreatment from the ritazaram trial that is still being analyzed. It's a similar setup, only the patient population was different. Patients were treated with rituximab for induction after having had a relapse. So you select for a high risk relapse population, you induce remission with rituximab, and then you randomize them at months 4 to either receive rituximab 1 gram every 4 months or azathioprine standard regimen. And also built in this trial is a randomization to 2 different glucocorticoid regimens, one the standard, the other one the more accelerated. So hopefully from this trial we'll also get some data in relation to glucocorticoid sparing. We hope to get the results of this trial also later this year. Now, can you individualize rituximab retreatment? Yes, you can. You can give it based on reconstitution of B cells and ANCA levels. If you have a relapsing PR3 ANCA patient and you do nothing when the B cells come back and the ANCA rise, the patient will relapse, as you can see by the higher BVAS score here. And you put him back in remission, and the next time when the B cells come back and the ANCA level comes back, you retreat him before you have measurable disease activity. You can keep him in remission. And the difference is, here you need to use steroids again, versus here you don't. So the French actually looked at this issue in the Main-Ritson study. It's a little bit different design than what we do at the Mayo Clinic. They said, well, we retreat patients if they have B-cell reconstitution or if their ANCA level goes up. Either way, they retreated them. And so they randomized the patients in the 500 milligrams every 6 months versus 500 milligrams only if the B cells came back or if the ANCA level rose. And they were showing the same efficacy with fewer rituximab infusions, but the same adverse events profile, which is actually low for their scheduled regimen. But they claim that ANCA was not helpful. Well, I have personal some disagreement with that, but that's practice differences. So, and a couple of slides and then we'll come to close. Can we retreat patients on a very individual basis? We can to some extent, but we still don't have the holy grail, which is really very accurate individual relapse prediction. And that's really what drives the ongoing search for biomarkers. And what do we have so far? Well, we've come up empty-handed so far, with the exception of having the best biomarker of all, the patient, and having an old biomarker, which if you look at it in the context of autoimmune disease is pretty darn good comparatively, which is the PR3 ANCA. Now, what about the patients? In the context of the WIGET trial, Wegener's granulomatosis etanercept trial, we had the patients complete a patient global assessment. We asked them, how do you feel, rated on a scale of 0 to 10, and do you think your disease is active? 0 to 10, mark your dot. And when you do that, the interesting thing is that the patient's score goes up significantly 3 months, one study visit before we as the physicians could actually detect it on BVAS scores, lab testing, anything that goes into the BVAS score. So when the patient, they know their disease. When they say, I think I'm flaring, we better listen. Now, what about ANCA testing? And this is my last slide. Factors are determining the clinical utility for relapse prediction. We looked at this in the RAVE trial. And overall, ANCA testing in all comers, when you apply the statistics, always comes back and says, well, there is no significant association with an ANCA rise and relapse. But first of all, most of these studies are done in patients who have all kinds of disease, including ENT disease and not much renal disease, and it is done in patients who were treated with standard treatments, cyclophosphamide followed by azathioprine or methotrexate. So this is different now. We found in the RAVE trial that it depends a little bit on the assay methodology. So if you do it with a direct ELISA, you're good. And we subsequently analyzed our Bioplex data. So currently used solid phase assays are pretty good as long as you use the same assay consecutively in the same patient. The most sensitive assays, the capture ELISAs, are not very good because they hardly ever turn completely negative. But more significantly, it depends on the disease phenotype that you look at, and the patients who have predominantly signs of capillaritis, meaning renal disease and diffuse alveolar hemorrhage. Not so much the patients with ENT disease. In those patients, you can use the PR3 ANCA serially to predict relapses, and we're not the only ones who showed this. A group showed that at the same time. And it is much more useful following rituximab therapy than after cyclophosphamide therapy. And why is that? Well, again, data from the RAVE trial that I'm not showing you here, only in 14% of patients after cyclophosphamide therapy did the ANCA go to zero, whereas it did go to zero in over 50% of the patients after rituximab therapy. So what drives the autoantibody down more significantly allows you to later on use the signal of recurring ANCA in a more predictive fashion. So with that, let me summarize. Rituximab has essentially replaced cyclophosphamide for remission induction in PR3 ANCA-associated GPA and MPA. What patients would we use cyclophosphamide in this day and age? Probably elderly people in whom fertility is not the issue, who have a new diagnosis with MPO ANCA positive disease. That's the subgroup in whom we still consider cyclophosphamide. But you need to be able to treat it safely, the patient, with all the necessary follow-up so that you can use cyclophosphamide safely. Plasma exchange has no apparent benefit in the management of ANCA-associated vasculitis. Glucocorticoid avoidance is our primary focus of clinical research currently. I showed you the example of the new complement factor 5A receptor interaction mechanism being the target of avacopan, a new agent that promises to put the kibosh on renal damage early and allow us to get by with less glucocorticoids. And then we have looked at more rapid tapering regimens in the context of larger clinical trials, including Paxivas and Ritazaram. And also in the same vein of steroid sparing is the use of more effective remission maintenance agents, particularly maintenance with rituximab, preventing relapses that occur during treatment with AZA and therefore saving prednisone exposure. And of course, we continue to look for more effective biomarkers that allow us to further individualize the treatment. And with that, I'd like to close and thank all my collaborators at Mayo Clinic in the various clinical trials that I participated in, the funding agencies, and particularly our patients, without whom we could not do any clinical trials and advance the management of the disease. And again, this is your beautiful hometown, which I had the chance to explore running yesterday morning. So really, thank you, Granada.
So, thank you very much. ¿Alguna pregunta en la sala? Yes,
Professor Specks, thank you very much for an excellent presentation. I'd just like to point out one thing, that there is data that from Mayo in a recent randomized controlled trial that David Jane and colleagues made using MMF, also showed that for patients with MPO ANCA, MMF is equal to traditional therapy. So I would argue that in this day and age, a patient who has MPO ANCA that has creatinine less than 3, that doesn't have pulmonary hemorrhage or cerebral involvement or retinitis, can be equally treated with a combination of steroids and MMF.
Well,
based on a randomized controlled study.
Yeah. So
and pilot studies too.
Yeah. Of course, like always, I agree with Dr. Favenza. And I particularly agree about the results of the paper which we jointly co-authored. I have to say, though, the Mayo study was not a randomized controlled trial. It was a pilot trial in a small group of patients, and we compared it to traditional historical cohorts, and the outcomes were similar. And there is a randomized controlled trial that now was published from the US, indeed, but that has some trial design issues that one can argue with, but at least if you look at the data in a very black and white fashion, you can say, yeah, probably equivalence. And I would not hesitate to use it in an MPO ANCA positive patient with creatinine less than 3 and no other significant severe disease manifestations. So I would not use it in someone with a creatinine less of 3 who has any inkling of diffuse alveolar hemorrhage, and we excluded those patients from our pilot trial. And we wouldn't use it in anyone who has any sign of peripheral neuropathy either. So that really shrinks the patient population in which you can safely consider mycophenolate mofetil very, very quickly. And you very quickly get into the realm of considering rituximab instead.
Is there any other question? Yes, Fernando?
Organ, it's very good.
Can you repeat that with a microscope so everyone hears it?
I appreciate very much the fact that you recognize that the kidney is the most important organ, but it's also important for us to know the other patients that you see that we don't see, the kidney. And specifically, what is the risk if you have an ANCA-associated limited disease, ENT, lung, what is the risk that those patients are going to evolve into a more severe form, specifically kidney? And how do you follow those patients?
Well, so there's a distinction between GPA patients that are ANCA negative versus GPA patients that are ANCA positive. And so the majority of GPA patients that are ANCA positive have PR3 ANCA, and those patients are at risk for relapses, including subsequent development of renal disease. If you have a patient who has a biopsy-proven GPA but is ANCA negative, that patient is not at risk for renal involvement until the patient seroconverts to ANCA positivity. And over my career, I've seen that in 4 or 5 patients, so it's not common. Probably because we watch these patients carefully, and because once you have a diagnosis, you got to watch them. And they're always at risk for subsequent relapses, particularly the PR3 ANCA positive ones. And once you monitor them, you get on top of any disease activity quickly, including renal disease. Now, in that context, since you're talking about patients, I, from my perspective, am very much concerned about patients with interstitial lung disease and positive MPO ANCA. We did not talk about this here, but it becomes more clear that a subset of patients that present with lung-only fibrosis can be MPO ANCA positive. And when they are MPO ANCA positive and don't have any sign of vasculitis in other organs yet, they have a 25% chance to develop microscopic polyangiitis in the next couple of years. So if I see an MPO ANCA positive patients with lung fibrosis, I make sure that they monitor their urine, either by going formal UA once a month, or I give them a box of hemosticks and have them check their urine for microhematuria themselves every Sunday. So they get into the habit to do it every Sunday and don't forget. And when it turns positive, they need a formal UA, and if that confirms that they have microhematuria, then they need evaluation by a nephrologist, because they're likely to develop renal disease. And as you know, the MPO ANCA disease has a tendency to fibrose more, but it does it slowly. So by the time you see them with a creatinine of 4, you're looking at mostly sclerosed glomeruli, whereas the PR3 ANCA positive patients, when they come in with a creatinine of 4, they have nice florid cellular casts, and you have a much greater chance of turning the renal function around in that subset than in the MPO ANCA subset. So in the interstitial lung disease patients with MPO ANCA, we need to be vigilant so that we get on top of the renal disease early. If they develop other signs of microscopic polyangiitis, such as peripheral nervous system neuropathies or alveolar hemorrhage, they become symptomatic and you can get on top of it quickly. But the renal disease is one that is often missed otherwise, so we need to watch out for the kidneys once again.
Okay, thank you very much. We will move.